Visible?
Yes, sir.
28 is 34 weeks gestation, Kyphoscoliosis. So challenges in this case are all due to thoracolumbar scoliosis. So you need to evaluate the severity, which may be the cause for the following complications. So an extent of restrictive lung disease due to kyphoscoliosis, airway difficulties, extent of restriction of lung development which had been present since childhood, and severity of pulmonary hypertension, problem of positioning, especially in the supine positioning of the patient is going to be a challenge if they have a hump in that, and difficulty in central neuraxial blockade due to alteration in spine alignment. Coming to airway management, difficulty in laryngoscopy and intubation due to distorted airway anatomy caused by spinal curvature. Increased risk of aspiration due to potential gastric distension during mask ventilation. So, patients with kyphoscoliosis may have a head and neck like this, very short neck with a long mandible. Mouth opening will be very much restricted because the chin will go and hit against the chest wall. So you may find it difficult. So you have to plan for an awake fiber optic intubation. And there was recently a case reported from the Kasturba Gandhi Hospital, Triplicate, where they performed a tracheostomy electively before administering GA for this sort of patient with a severe kyphoscoliosis. So that case report only gave me the idea of asking a case like this. Supposing they keep a case like this in the exam, you should not be caught unaware. So this is an unusual case which triggered the idea of asking this question. Then respiratory complications, restrictive lung disease leading to decreased lung volumes and potential hypoxemia, particularly during pregnancy when oxygen demand is increased. Difficulty with ventilation management due to altered chest wall mechanics. Then neuraxial blockade challenges in these cases are difficulty identifying the spinal landmarks. This is little bit of exacerbation of these 5 points that I have given earlier, and increased risk of uneven block distribution or inadequate block depth due to distorted anatomy again. So imagine a patient having this and you have to give a spinal here. Okay, so always go on the convex side so that the spinous interspace will be open here. So if you go on the concave side, you will have a narrowed space. So go on the convex side. That is the clue that you can take. And cardiovascular concerns are potential for decreased cardiac output in severe kyphoscoliosis, which may the need for extensive monitoring, possibility of severe pulmonary hypertension or call pulmonale or RVH in case the lung development is rudimentary, positioning difficulties, challenges in finding a comfortable and stable surgical position due to spine deformity, and you may require adequate padding to keep the patient in the correct position. General anesthesia indications are maternal preference, severe maternal cardiopulmonary disease, or unsuccessful neuraxial anesthetic technique. So these are the indications for that. So early preoperative evaluation is important to identify the musculoskeletal and cardiopulmonary disease by taking a thorough history and a physical examination and workup of the cardiovascular and pulmonary test, and management of difficult airway. Prior spinal surgery, including surgical correction of scoliosis, is not a contraindication for neuraxial blockade. So you can still go ahead and do it, but it may be technically quite challenging. And previous surgery may also distort the epidural space, interfering with the spread of local anesthetic, resulting in patchy or unilateral block. And spinal fusion with Harrington rod and other mechanical gadgets will hinder pre-procedural positioning because patient cannot bend. Usually they are all having a very stiff back. So bending the patient and identifying the spinous process will be problem. So this is an algorithm given in that article of the anesthesia tutorial of the week, where they have the degree of scoliosis, mild, this Cobb's angle between 11 and 25. The neuraxial technique you can use is it provides a confident provider with a anatomy and proceed cautiously with good positioning. And for moderate Cobb's angle of 25 to 50, a paramedian approach on the convex side, a midline approach with the angulation towards the convex side, and an imaging technique using ultrasound. So these are all the methods by which you can achieve a neuraxial blockade. In severe cases of more than 50 degrees, imaging technique is definitely needed, and the fluoroscopy also should be there to identify the safe placement with a low threshold for alternative plan also should be kept in mind, because the chances of failure rate or unsuccessful block is very high in this category. So you must always keep a backup plan of GA in these cases. So this is the classification given in that particular thing. So the main problems are the five things which I told you in the beginning. Okay, so make a thorough evaluation of the kyphoscoliosis and look for the pulmonary restriction on the side of narrowing, and the rudimentary developmental uh, arrest of growth of the pulmonary lung is very important, which will be resulting in pulmonary hypertension, called pulmonary, and all those things. Of course, these things, once if they are present, it will be clinically very evident. Patient will be always tachypneic, breathless, may have cyanosis. All these things will be very evident in that case of severity. But if it is mild, then you have the choices of going for regional as well as your general anesthesia. And in general anesthesia, airway difficulty has to be kept in mind, despite the fact it may be a thoracolumbar kyphoscoliosis, but the neck will always be, because of the chest abnormality, the neck movement also will be restricted in these patients, as I showed in the picture. So you have to make a thorough evaluation of the airway also before you plan for GA in these cases. Okay. Is it okay? Any
Yes, sir.
doubts on that? Ready 2 hours. Shall we go for ASCII now? You have any?
Yes, sir.
Okay.